Hi, everybody, and welcome. My name is Mika Iofi, and I'm a member of the Public Education Committee for ADAA. That's the Anxiety and Depression Association of America. So welcome to our webinar today, Selective Mutism from Diagnosis to Treatment. And our presenter is Dr. Rachel Busman. Before we start, I'd like to say a little bit about ADAA, the Anxiety and Depression Association of America. ADAA is the leading nonprofit organization in the field of anxiety and depression. Our mission is to improve diagnosis and promote the prevention, treatment, and cure of anxiety, depression, and stress-related disorders through education, like this webinar, and practice and research. We work to end stigma and to get the word out that these conditions are real and serious and very much treatable. I want to invite you to visit the ADAA website. It's a fabulous resource, and that's adaa.org. You'll find a great list of treatment providers. Just click on Find a Therapist from the homepage. As well, we have a free peer-to-peer online support group. And you can support ADAA by making a charitable donation on the website. Okay, so let's get started.
I now present to you our presenter, Dr. Rachel Busman. Dr. Rachel Busman is the Senior Director of the Anxiety Disorders Center and Director of the Selective Mutism Service at the Child Mind Institute. She leads a team of clinicians providing evaluation and innovative treatment to children with selective mutism. Dr. Busman is President of the Selective Mutism Association, the nation's largest network of professionals, families, and individuals with selective mutism. Dr. Busman has extensive experience providing cognitive behavioral therapy to children, teenagers, and young adults struggling with anxiety disorders and school difficulties. She also has specific interests and expertise in the evaluation and treatment of obsessive-compulsive disorder, separation anxiety disorder, social anxiety disorder, and specific phobias. Dr. Busman has worked with children in both inpatient and outpatient settings at a major academic medical center where she directed a multidisciplinary team. She has taught and supervised psychiatry residents and child psychiatry fellows and lectured extensively on a variety of topics, including the evidence-based assessment and treatment of anxiety disorders in children and teens. Dr. Busman works intensively with children who have selective mutism and is dedicated to establishing trust and instilling a sense of hope in her patients as she helps them on their path to recovery. We now turn the presentation to Dr. Rachel Busman.
Thank you so much for having me. All right. Thank you so much for having me. And I'm definitely going to get started in just a minute and just start by saying thank you very much for the very lovely introduction. This is definitely an area of interest for me where I do a lot of my clinical work. So I certainly have lots to share, and you know, an hour is definitely never enough time to get through everything. So if you guys have questions, if the hosts have questions, they will jump in as they may. So we're going to talk about selective mutism, and we're going to start with sort of a primer on selective mutism, because honestly, it's, I think, a misunderstood diagnosis, and I think one that doesn't get talked about enough. I always use the example that even in graduate school for me, where I focused on my child and adolescent clinical work, it was not touched upon for more than maybe a minute or two in graduate school, which, you know, and that was a while ago, so hopefully there's more that gets talked about now, but I think overwhelmingly it's not a well understood disorder, so I hope to shed a little light on it. So you always start by talking about fear and the fear response before going into specifics about selective mutism, because really it's important to provide a little bit of a framework for setting the stage for anxiety disorders. So fear is something we all experience. It manifests itself in different ways in different people, but there's some pretty common responses to a threat or a fear that all people have, which is really normal and very adaptive when you're actually facing something threatening or something that would put you in danger. And what usually happens is that we go into fight or flight, and usually that means that we either quickly flee a situation or do something to sort of fight the situation. Sometimes people freeze, which can definitely happen when facing a stressful situation. But it's very normal for your body and your brain to sort of quickly react in a stressful situation, because if we didn't react quickly in times of cavemen and woolly mammoths, we would get eaten. And I always use the example of driving home on a night when a deer jumps in front of my car. If I didn't react quickly, someone would get hurt. So what happens is your heart starts to race, and maybe you feel a little bit queasy, and maybe you're thinking a bunch of different things all at once, but what happens is you react quickly. In the case of me and the deer, I slammed on the brakes and then avoided hitting the deer. And then after that threat passes, my body sort of resets and it becomes, my breathing returns to normal, and maybe I'm not shaking anymore. And so that is a very normal and rapid process that happens to people in the face of stress. When we talk about kids with anxiety, we often are talking about kids who kind of have an overactive smoke detector or fire alarm, where maybe they are perceiving threat or danger where there either isn't any, or their response, the child's response, is sort of an extreme version of what would typically be expected. So a lot of times we get asked, or I get asked, how do I know when anxiety, like what's too much anxiety? How do I know when something is really a problem versus, quote, normal? And so we think of these three things before we make a diagnosis of really any disorder, but we're going to talk more specifically about SM or selective mutism in a minute. But we think about and we talk about frequency. So we have a way of sort of categorizing different disorders, and usually we look at how many symptoms of a disorder a child has, and usually you need to have a certain number. That is a little arbitrary to some extent, but also helps to clarify if something is just a little bit of a problem or really more of a problem. So frequency of symptoms, duration, meaning how long has the child or the person been having these symptoms. So for anxiety disorders, it ranges. For selective mutism, it's a month of symptoms. And then impairment is really a very important component because what we're talking about is interference in one's ability to do their job. Now, when I say this, people say kids don't have jobs, and I would say they do have jobs. A child's job is to have fun and to play and to go to school and to be part of a family and to do different kinds of social things like have play dates and go to different activities. And if a child's anxiety is such that it's impairing their ability to function as a student or as a friend, then we would say that that's causing impairment. So you need these three things to make a diagnosis. So let's talk a little bit more specifically about what selective mutism is. So first of all, selective mutism is an anxiety disorder. So if you look in the Diagnostic and Statistical Manual, which is just a big book of all the different disorders, you will find it in the chapter on anxiety disorders, which is actually a good thing and you'll find out why when we talk about on the next slide about myths. But so selective mutism, or SM, as I'll refer to it in the rest of the presentation, is when a child is unable to verbalize in specific social situations where we would expect speaking, despite being able to speak just fine at home. So there's a lot of words on this page, and I like to just be straightforward. So basically, people will often say, my child is a chatterbox at home. He or she doesn't stop talking. I can't get her to get out, from dancing and singing, and she's like very articulate and bubbly. And then you see the child at school or on a play date or in an activity, and they look completely different. So the first component is that there's a discrepancy between how the child is speaking in different situations. And this often occurs in places like school, in places like music class, ballet, play dates. It also often occurs with family that the child does not see often. So I often hear grandma who lives 5 minutes away and takes care of Susie 2 times a week. She talks just fine with that grandma. But grandma that lives in Florida and we see her twice a year, we need a lot of warm up time with that grandma. And it's not because we don't like grandma in Florida, it's that there's much less practice talking with that person. And we'll talk a little bit more about what that means. So the other things on this slide really just discuss what I was saying before, that this is impairing. It's not just like very rarely this happens, but this is really the child's state of being. And it's not exclusively in the first month of school. Why that's in there is because some kids, when they enter school, they might be a little bit hesitant to speak, or they might take a little bit of time to warm up. And so, but the kids that have a selective mutism diagnosis often haven't been speaking for many, many months, if not longer, at school. And the last thing that is not a diagnostic criteria, but is just true from the experience that I and our practice has had treating hundreds of kids, is that there are very unique variations from child to child. So some kids might speak to their parents in all places. So the mom or dad or other caregiver could go into the school building and the child still talks to the parent, and other children stop talking 2 blocks before they enter the school. And so it just speaks to that some kids have what we call more rigid boundaries, and some kids have less rigid boundaries. Okay, I really like this slide because it addresses the myths that are really common to have about selective mutism. And actually, I love when someone says something like, hey, isn't that the same thing as shyness? Because then I get to say, oh, I'm so glad you asked that question. No, it's not the same thing. So we're going to go through some of these common myths. So I mentioned a minute ago that selective mutism is an anxiety disorder. And it wasn't always considered an anxiety disorder. It was in a different chapter in the DSM. And it also used to be called elective mutism, which is really not a great name for it. To me, it immediately makes you think willfulness or choice to speak. And one of the biggest myths that we hear a lot is that, oh, Johnny's refusing to talk. He wouldn't answer my questions, which really leads you to think the child's being stubborn, the child's being controlling, the child's doing it on purpose in some way. And that really is not a helpful way to think about anxiety disorders, and it's not a helpful way to think about SM. So whenever anyone says he's refusing to talk, I usually gently say something like, oh, he wasn't able to talk. And I don't mean physically able. I don't mean that the child can't form language. What I mean is that the anxiety is getting in the way. So what I'll also say before we move on is that SM, in order to have this SM diagnosis, one other piece I didn't say is that while it causes impairment, it's not primarily due to a language disorder or a discomfort with the language. However, you do see, not surprisingly, a higher rate of speech and language disorders in this population, but you can't be diagnosed with selective mutism if the reason for not speaking is because the child is having a very severe speech or language difficulty that would better explain the non-speech. Similarly, a child who is in a language environment where they do not speak that given language, that would not be accurate to say that it's selective mutism. Although we do actually see a pretty high number of kids who are multilingual. And if we have time, we can talk a little bit about what that is. So social phobia. There is a very high rate of overlap or co-occurrence with social anxiety and SM. I would actually say, because they're both anxiety disorders, they're kind of like cousins and they hang out together, but they're not exactly the same thing. So SM is specifically specific to speaking, whereas social anxiety is a little bit different. So social anxiety disorder or social phobia is the fear of embarrassment or judgment, or negative judgment or evaluation. And it could relate to speaking, but it also includes things like, might include drawing, it might include performing or writing, or worrying that how you look, because people might think what you wear is stupid or that you look dumb. Now, as I said, a lot of these are overlaps, right? And so many kids might show symptoms of both. It's sometimes hard to distinguish and discriminate because there are some overlapping symptoms. However, many of the kids we see who have just SM and not social anxiety tend to have no problem raising their hand in class to do things that involve participating as long as it doesn't involve talking. Or they probably have no problem eating in front of other people, showing their work that doesn't involve speaking, whereas kids that we see that have social anxiety might also be very inhibited, very slow to participate in like gym or music class. Again, not during speaking activities, but there are a lot of kids who have social anxiety are also concerned about things that go beyond just speaking. Sometimes people will say something like, well, did something terrible happen to the child to make them stop talking? And while kids do experience traumatic events, and some do develop PTSD or post-traumatic stress disorder, that and SM are quite different. Some kids who experience a trauma and go on to develop PTSD might avoid talking about things related to the trauma. So for example, if there's a fire, they might not talk about fire or fire engines or things like that. But children who have SM are not speaking across situations and not related to a specific trauma. And again, the literature is pretty sparse in terms of saying that trauma is something that causes SM. Outgrown is a really important one to talk about because unfortunately there are a lot of pediatricians and primary care doctors who might see a child for a well visit. The parent says, my child isn't talking, and the doctor says, oh, she'll grow out of it. Oh, she's just shy. And I actually think that in some ways those are the more damaging kind of comments because anxiety disorders are not outgrown. And in fact, kids who aren't talking for a year at school, it actually becomes often worse. Now, there are people who outgrow it, and I would say that it's not uncommon to, when we interview a family and meet a new child for the first time, we hear, that maybe one parent on one side of the family, either they themselves or know somebody who might have had SM in their family and they kind of turned out okay. But the risks of not evaluating and then treating SM far outweigh the benefit of waiting and doing nothing, especially when we have some really good treatments out there. Shyness is, again, different than SM. Shy is more of a temperament, a trait where I would say it's a child who maybe observes when they walk into a situation, but with a little bit of time, they're slowly warming to the situation. That is very different from SM. And in some ways, we run a program called Brave Buddies. And so oftentimes after, maybe the couple days in, you can look around the room and we see many kids who we might actually say, yeah, she's a little bit more introspective or she's a little bit more inhibited. But we actually see many kids who are far from shy. They are very much almost social butterflies without words, as one parent we worked with said. So shy and SM are not the same. And then I'm just going to kind of quickly go through the last three little pictures. So autism is very different from SM. I think the main reason why people and often schools think autism or treatment providers think autism is because children who have SM often are not talking to their peers. They often are not making eye contact. They often can look a bit disengaged. And so it would be reasonable to ask about a child's development and developmental history to see if that's consistent with autism. However, if you look at video, which we do, of kids with SM at home when they're comfortable, they are often quite engaged in conversations, very interested in other people. They often have really great reciprocity, and that is not consistent with autism. I would say for any kind of like learning disorders or language disorders, it's hard to evaluate a child when they're not speaking. And so sometimes teachers will say, well, I wonder if she's understanding what I'm asking, or I wonder if she has a learning problem. And a vast majority of kids that we see don't have learning disorders. Yes, many kids also have some language difficulties, but the main point is that you can't adequately assess a child by doing an evaluation through school when a child isn't speaking at all. So when parents come to me and they ask, I wonder if my child has any kind of learning or language issues, we usually will say, let's treat the selective mutism and get your child talking, and then we'll better be able to evaluate their academics and their language. So we know what selective mutism is not. So what is it? It's a product of nature and nurture. And so what does that mean? Like most disorders, learning disorders and other psychiatric disorders, there's a bit of genetics. How much? I don't know exactly how much, but I would say that family history and genetics play a role in sort of setting the stage for what we would call predisposition to anxiety disorders. However, when I'm in a room with parents or in a room giving a training, I usually say, raise your hand if you have more than one child. A lot of hands go up. And then I say, raise your hand if those kids are really different people. And of course, the hands go up again. So kids are different, and kids with the same parents may, genetically be very similar, but have very different presentations. So genes are a part of the puzzle. Nature or nurture rather is really important here, and we're going to spend some time talking about it. So when we talk about nurture, we're talking about anyone or the environment's interaction with the child and how that actually reinforces, and not in a good way, not speaking. So that's a lot of language for me to say. So I'll just basically say that it kind of helps people understand how the SM gets maintained. And so what we're going to talk about today are actually some behavioral strategies to sort of reverse that cycle. So this is a circle of what we call negative reinforcement. And so I'm going to have to play both sides here because I can't see everybody who's watching. But what usually happens is something like this. A child is prompted to engage some way. So, Jackson, what were you for Halloween? And let's say that's a teacher that asks. And what happens is the child does a bunch of different things. So some kids with SM just look right back at the person, kind of stare at them, deer in the headlights. Other kids look away. Some kids look obviously anxious. And some kids might, cover their face or put their fingers in their mouths. And we probably all describe that as inhibiting their response in some way, and that they were probably in distress. Even if it wasn't a ton of distress, it could range how much distress. And usually the people or the person who asked the question and the parent or caregiver who is there too maybe sees the child not answering and looking one of the ways I just described. And then usually, because I like to think that people are usually nice, the environment reacts in an empathic way. So, Jackson, what were you for Halloween? He doesn't answer. And then the parent says, he was Harry Potter. Or maybe the teacher or the person who asks tries to make the situation a little bit lighter and says, you must be shy, or, ooh, let me guess. But basically what happens is somebody probably jumps in and the question doesn't get answered. And then what happens is it makes it much more likely for that whole cycle to happen again. Similarly, let's say the person knows the child was Harry Potter and says, oh, were you Harry Potter for Halloween? And the child nods their head. We would probably all think, well, that's good. She shook her head. But what actually happens is if the child shakes their head and then the person who asks says, oh, yeah, you were Harry Potter. That's so cool. I was Hermione. What ended up happening is we just reinforced the child nodding their head, meaning we took the nodding as talking, when in fact it wasn't talking. So what ends up happening is kids with SM get a lot of practice not talking. And the people who jump in and maybe rescue by answering a question for them, I would say I understand exactly why a parent might jump in or a teacher might jump in to answer, because when your child is in distress or your child is struggling, the first thing a caring adult would do would be to jump in and try to make that situation easier. That's very normal for parents to do that. But what ends up happening is it becomes this pattern that continues to happen. So a learning history is just a fancy way of saying when you get a lot of practice, it becomes sort of very routine. Like, let's say a child, you have 180 days of school and you have 180 days of not talking to the first grade teacher. It's going to be pretty hard to undo that cycle, harder than, for example, maybe even a brand new person that you have no history with. So hopefully that makes sense to everybody. So what I would say is, and I would say this is sort of the general understanding of about, cross-culturally, this is a disorder that exists it's not unique to the United States. We have treated here at Childmind, we've treated children from all over the world, and children all over the world have selective mutism. So it is not unique to the United States, and it ranges from anywhere from about 0.3 to 2%. Usually seen more in females, and we could probably have a whole discussion about why that is and if that's, something unique to females or if it's more unique to how we seek help for girls versus boys. I'm not going to actually get into it too much except to say that there is a higher rate diagnosed in girls. The age of onset is around 3 or when a child enters school or daycare, but the average age of diagnosis is actually 6, which lets us know that there's a real gap in when we notice it to when we have diagnosis and treatment. And I know that ADAA, one of your missions is to, dispel stigma and sort of increase access to healthcare. And I think that we want to also bridge that gap and get people to reach out and seek treatment sooner rather than wait. It does not tend to remit on its own, and it's associated with negative short and long-term outcomes. So we know that long-term outcomes for untreated anxiety disorders include a lot of things, including school problems or problems with substance use, problems with dropping out of school. We don't worry about that so much when a child is 3, but we do worry about not being able to make friends and not being able to navigate a classroom and things like that. So I want to just quickly talk about what the literature tells us, because the rest of the slides that I'm going to talk about are geared towards the type of treatment that we do at Childmind Institute. And so that's a specific type of treatment. So there's lots of literature, and you can probably find a lot of support on ADAA.org around the literature tells us that CBT, or cognitive behavioral therapy, is a really good treatment for kids with anxiety. And what does that really mean? Well, C for cognitive means thoughts and B for behavior. And so it's a treatment that looks at how thoughts and feelings and behaviors are sort of all interwoven. And it's a type of treatment that's pretty directive. It's pretty it's pretty specific to the specific disorder. So someone who has depression, the treatment is going to be very much focused on the depressive symptoms and increasing things like getting the person out of bed and getting them up and moving. It's very specific to the disorder. Unlike other treatments, like let's say supportive psychotherapy, which might also work on depression or anxiety, but isn't necessarily targeted and specific to that disorder. It might be more about talking about what's on the person's mind that day, or just kind of sometimes more venting or kind of focusing on what's present that particular moment. Now for SM, there's been less literature, and that's probably for a variety of reasons. It's a pretty very specific anxiety disorder, and because it's more recently been categorized as an anxiety disorder, it hasn't always been included in larger scale studies that looked at anxiety in children. But I did put a list of some articles here. Bergman, basically the first three are what we call randomized control trials, which are basically a fancy way of saying a very stringent method to doing research, where there's a control group and then there's a treatment group, and the researcher collects a good amount of data to verify that the treatment that they are looking at works. And so Bergman, who did a randomized control trial in 2013, Orvac did one in 2013, and then he went and did a 5-year follow-up in 2018. And those studies support a behavioral intervention or a behavioral approach to the treatment of SM. Now, Carpenter, Pugliafico, Steve Kurtz, and colleagues in 2014 wrote an article about how to adapt PCIT, which is parent-child interaction therapy, for anxiety disorders. And included in that article was an adaptation for SM. And that's what I'm going to talk about for the second half of the presentation. And then Cornacchio, this is in press, so I don't, it's very recent, but it was the first randomized controlled trial looking at behavioral treatment for PCIT adapted for group. So meaning the intervention was group-based treatment, which showed positive results. All in all, it's really important to find a treatment that focuses on the speaking and also works towards something called generalization, which is a fancy way of saying you want the gains, you want the speaking to not only occur with the therapist, but you want to have it generalized to more people, to more places, and more settings. So hopefully that makes sense to people. So when someone says, is my child going to talk to you? I would say something like, that's a great question. I hope so, but I care only so that it's a vehicle to talk to other people. And hopefully that makes sense to people. So before treatment, and I think I'll just say this briefly, before any treatment, you always want to have a comprehensive diagnostic evaluation. And I'll just say briefly that means that the mental health professional spends a pretty significant amount of time with the parents and the child to evaluate what the problem or problems are. And so sometimes parents will say, but I don't want my child to get a label. Isn't that bad? And what I would say is actually a label, like if the diagnosis is selective mutism, we want to know that so that we know how to treat it. Similarly, if a diagnosis is selective mutism and a phobia, or selective mutism and a mood disorder, we also want to know that so that we can give the best treatment. So we feel that diagnosis drives treatment. I won't be talking about specifically here what our evaluation process is, but I will say that it is very hard to evaluate a child by doing a clinical interview with a child who isn't speaking. So we don't do that, and hopefully that would be something that a treatment provider, if you're looking for one, would be able to tell you what they do. We do an observation of the child and parent so that we can see what the child looks like when they're alone with the parent and then in the presence of a stranger, but we don't directly ask questions to the child because that would not make much sense, since a child is the thing they have such difficulty with is speaking. So as I said, the goals of treatment are to increase the number of people, places, and activities where the child speaks, both responsively. Now, responsive speech means I ask a question and you answer, so that's responsive speech. And spontaneous is when you talk all on your own. So if a child said, I really got a lot of Halloween candy, then that means that was spontaneous because no one asked them a question. A big component of treatment is building something called distress tolerance, which basically is a fancy way of saying getting comfortable being in situations that can cause a bit of distress. So, and this often is harder for the parent than the child. So meaning, do you mean we're going to play in a room and you're going to come into that room? That sounds really stressful. Yeah, that might end up being stressful. And then we would teach the parent and the child how to handle when someone comes into a room that you don't know. And you'll see diminished anxiety is crossed out, and just means that we don't start treatment when anxiety has already subsided, because we might wait. It might take a long time for that to happen. Some kids, older kids, will report to us that they still feel like things are hard even when they're doing them. And so the way I describe this is, if I have a fear of tarantulas and I want to get over it, and you say to me, I can help you with that, just let me know when you're not scared of them anymore, and then we'll start facing our fear, I would say that probably isn't going to happen. Versus if I said, I really, for some reason, want to hang out with tarantulas, and you say, okay, we're going to start by looking at pictures of tarantulas, you're probably going to be a bit anxious, but I'll help you get through that, and we'll cope together. Hopefully that makes sense. So treatment. So our treatment involves this PCIT, this adapted PCIT, which I talked about a moment ago from the Carpenter Poliafico-Kurtz article. And PCIT is parent-child interaction therapy. Again, lots of acronyms, but just the best way to explain it is, it's a treatment that heavily involves the parent, and we coach parents in the use of very specific skills with the goal of helping their child speak more. Now, if you're wondering, but my child speaks it with me, that's absolutely correct, but there's probably 99% of the time outside of the home where the child is struggling, and we want to give parents skills and make them very familiar in using the skills so that when they go into these situations, they know what to do. And it starts with education, which is one of the things we're doing right now. So we want to debunk myths. We want to be collaborative with people like school, other family members, other providers like pediatrician or psychiatrist, if there is one. And so I'm going to actually stop there and see if there are any questions before I go on. Okay, cool. Okay, so skills training. So SM therapy involves two things. So if you look on the left, there are two sets of skills that we use, CDI and VDI, and those come from that adapted PCIT. PCIT, as I had said before, is parent-child interaction therapy and is associated with Sheila Iberg and Cheryl McNeil. And so there's an adaptation there with two sets of skills, a reward set of skills, a no question set of skills, a let your child lead set of skills, and then a question asking set of skills, which is the verbalization directed interaction. On the right-hand side of this slide is kind of, okay, great, now I know the skills, what do I do with them? Well, a goal would be to pass talking from one person to another, like from mom to teacher, or from dad to great Uncle Joe. And exposures are basically purposeful and systematic situations where you take the skills on the road. So for example, if you go to the library with the goal of your child telling you what book they want, that's an exposure. Why is it an exposure? Because you planned to do something that's probably a little bit uncomfortable with the plan of helping your child build their brave muscles. So we're going to switch into learning some skills, which I realize is hard to do via webinar, but we're gonna do it. So the good news is that you can probably watch the webinar and pause it and then practice and then start it again. So child-directed interaction, or CDI, are the skills we use. These are the do skills. So these are the skills that you use when you're not yet prompting your child to talk. So these are skills that you can use in situations like when you get to a birthday party or you get to a family gathering and your child's not yet ready to be asked questions, maybe even by you. And these are skills that really kind of let your child lead a little bit and take the pressure off. Pride is the way to remember them. We can thank PCIT for that. And so the good news here is that all of these skills are really good for all people and all kids. Meaning if you're wondering, hey, I wonder if this stuff will help with anything else, it will, because parent-child interaction therapy was originally developed for kids who had some disruptive behaviors and inattentive behaviors and aggressive behaviors, and it was adapted. And so we know that it's really helpful in getting kids in shaping behavior. And so you're going to learn in a minute why it's really helpful. So P for praise, but it's a special kind of praise, labeled praise. So if you think about the fact that praise, when it's specific, increases the likelihood that you will see the behavior again, then it'll make sense. So if your child says, if your child comes into the kitchen and they have their shoes on and their coat on and they're ready to go to school, and you say, great job getting your coat and shoes on, that is a beautiful labeled praise for being ready for school, and it actually increases the likelihood that your child's going to do that again. So being specific about what behavior you're talking about helps the child know what it is they did that was great, and it also increases the likelihood that it'll happen again. So praises for speaking sound like, great telling me, thanks for answering, great question, I love hearing your voice, thanks for telling me, thanks for telling Susie. Now, sometimes people will say, my child hates praise, and if I thank them or I call attention to it, they're going to hate that. And what I would say is that may be true, and it may be true because it does call attention to it momentarily, but it actually gives your child practice hearing it and handling it and being able to move on. So I'm not saying throw a party. I'm simply saying you would say, great answering my question, or thanks for telling me. So P for labeled praise. R for reflection. A reflection is simply repeating what your child has said as a statement in a regular tone of voice. So if your child says, I like pink, you would say, you like pink. If the child says, I was Harry Potter for Halloween, you were Harry Potter for Halloween. It's simply a repetition. It also actually serves to increase speech. So if you actually put a reflection or a praise right after your child talks, for the kid with SM, it actually helps do something called positively reinforced speech. So the child says, I was Harry Potter, and you say, great telling me, or you were Harry Potter. So praise and reflection. I'm going to skip the I for a minute. Describe refers to play-by-play announcing. So this is something that is actually really helpful to do when you're playing with your child, or let's say you're at Aunt Susie's next week for Thanksgiving, and you know your child needs a little bit of warm-up time, so you take a bag of fun and you go into the guest room, and your inclination is to ask a lot of questions, but you'll see that you're not supposed to ask questions during this time. So what you can do is you can describe what your child's doing. I see you're unpacking the bag of stuff that we brought. Oh, you're taking out the crayons and the coloring book. That's such a great idea to take that out. See, I stuck in some praise. And then let's say your child says, I want to color, in a really soft voice. You want to color. Thanks for telling me you want to color. I see you took out a piece of paper, and now you're taking out the crayon. So all those narrations describing what the child is doing are descriptions. What it does is it shows you're paying attention to the child and you're following their lead. And then if you mix in some of your own imitation, meaning, and it doesn't mean copying, but you might say something like, that looks like a lot of fun. I think I'm going to do that too. I actually really like to color. Then you're showing your enjoyment and that you're invested in your child's activity. And now you have the pride skills. So the way that now when your child's not talking at all, you really can't praise or reflect their speech because they're not saying anything. So all you really have are descriptions. So this is where I would say you can put in your own little comments as well, so it doesn't sound so awkward, because it will sound awkward if you say something like, now you're taking out a pen, and now you're drawing a line, and now you're drawing another line, and now you're connecting those lines. That's awkward. But what you can say is, if you listen to what I say and try to hear some other skills thrown in there. Thanks for sitting down in the room with me. I love playing, and I think it'll be really fun if we draw some pictures before we go into the Thanksgiving dinner. I see you're taking out some paper, and now you're taking out some stickers. Oh, thank you for handing me a piece of paper. I'm going to draw a turkey So you'll hear that I described what the child was doing in this situation, but I also kind of put in my own little comments and I praised the child for what I could praise them for. You'll notice these are the don't skills. So when you're in CDI, you're not asking questions, which is incredibly hard. Some of these other things make sense, like you wouldn't be criticizing or being sarcastic. But you also aren't doing something that's really important called mind reading, which is something that we all do all the time. So for example, let's say you're playing in that imaginary room before you join the Thanksgiving dinner, and your child puts their hand down on a piece of paper and traces their hand, and you say, "Oh, you're drawing a turkey," and the child nods their head. You just submitted, you just kind of were mind reading. Now, we all have been in school where we put our hand down on a piece of paper and we trace it and we make it into a turkey. However, if you mind read, then you're speaking without actually knowing exactly what the child is doing, and it kind of deprives them of the opportunity to tell you. If you said something like, "I see you putting your hand down on the paper, and now it looks like you're drawing the outline of your hand. I see you're doing one finger, two fingers." You know, I used to do this when I was in school, and I can't remember what we used to draw. The child might actually say, "I'm drawing a turkey." And then you could say, "Oh, yeah, turkey, that's it. Thanks for telling me." Now that's going to work a lot better with younger kids. You wouldn't say to a 9-year-old, I wonder what you're drawing. You use maybe a slightly more casual approach. But mind reading is harmful because it deprives the opportunity to speak. Similarly, we consider pointing to be not pointing, but submitting to a nonverbal is actually mind reading. So when if a child is pointing, we want to get in the habit of saying, "I see you pointing," rather than, "Oh, you must want water because you're grabbing my water bottle." Okay, so those are the CDI skills. Any questions for those skills? Okay, so we're going to go on to VDI. So VDI is the planned and intentional use of prompts in a systematic way. Now, what does that mean? It means purposefully asking a question in a thoughtful way. It helps the child practice, and it always follows CDI, and it's never really used alone. So what I'll say is this: for kids that we've worked with for a while, even though the child has already been verbal, we never start a session with just questions, because we assume that there's always some amount of warm-up needed. So it's a dance. CDI and VDI are kind of like a dance, and kind of like driving a car and shifting gears. So there are 4 types of prompts, and this might seem overwhelming, but we're going to narrow it down. So go to the right-hand side where it says yes, no. So if I say, "Do you like chocolate ice cream?" and I say that to a child who has SM, there's an extremely high likelihood that they are going to nod their head or shake their head. Why? Because that's an effective way to communicate, and it doesn't involve speaking. So one way to stop that is to stop asking yes/no questions, which is also incredibly hard, but it's one of the VDI rules. So we actually tend to go to forced choice and open-ended questions, and we'll actually talk about forced choice more often. So you could say something like, "Do you like chocolate, vanilla, or something else?" Now, why something else? Well, a lot of kids, now we have some kids who I could say, "Do you like chocolate or vanilla?" And they would say, "I like strawberry." And then you could say, "Great, telling me you like strawberry. And you even chose a flavor I didn't even give you." However, there are some kids who might say nothing because you actually didn't give them the option that was correct for them. So we tend to do "or something else" as like just in case I didn't give you the choice that you wanted to say. So do you like chocolate, vanilla, or something else? Or you might say, "What's your favorite flavor?" Another way to ask or prompt is to say, "Tell me your favorite flavor ice cream." tell me your favorite flavor is different than, do you want to tell me what your favorite flavor is, which is actually a yes/no question and what we would call an indirect way. I'll give you the example that when I get my son ready for bed, I do not say, maybe you could brush your teeth, or do you want to brush your teeth? That is very hedgy language. Rather, I say, go brush your teeth, or please brush your teeth. Okay, so now you have the types of prompts. We're going to stick with forced choice prompts, and we're going to go through an example. So here's the thing. VDI means that I'm going to now give you the skills to know what to do no matter what the child does. But it does not mean the child's going to answer. So we have to dispel that myth. Okay. So I'm wondering if I can make this more interactive. Can I put the hosts on the spot? Oh.
Hi, yes.
Yes, good. Okay. Thank you for answering my question. So I'm going to prompt you, and I want you to answer me. Okay. So is your favorite food for Thanksgiving turkey, stuffing, or something else?
Stuffing.
Stuffing. Thanks for telling me. So I didn't have to wait very long because she answered right away. She said stuffing, and I actually praised and reflected. So that we would call that that I just went through what the sequence is for when you get a verbal response. So now I'm going to do it back so that they have a chance to do it. So one of you ask me a question.
Is your favorite holiday Thanksgiving or Halloween or something else?
Thanksgiving.
Great. Thank you for telling me that. You love Thanksgiving.
Exactly. So this is great. I can't even see them. And they asked a question. I waited a few seconds to answer. They waited patiently. You see, it's actually your rule is you got to wait 5 seconds. And then I answered, and I got not only a reflection, but a praise too. And if we had a sheet in front of us, like if you were here in the office, she would also give me a check mark towards a prize that I'm earning. So now let's go to nonverbal. This I can't demonstrate, but I'm going to walk you through it. So let's say I say, do you like turkey, stuffing, or something else? And the child shrugs their shoulders. If you said, oh, you don't know, that's probably a hard question. That's called mind reading. What we actually want to do is we want to describe right away what the child's doing. I see you shrugging. And now you have to think of, if I had one more chance to ask this question, I want to give it my best shot. So we call it either jazz it up or remind the child about the bravery sheet. So let's say the child shrugs their shoulders. And I'm doing a little assessment in my mind, which is like, maybe they're shrugging because they really don't know. Maybe they have no idea because like I'm thinking Thanksgiving's my favorite holiday. So of course I know what I like to eat, but maybe they don't. So I might say you're shrugging your shoulders. And I might jazz it up by adding a few sentences like, that question was really easy for me because I love Thanksgiving and I love the turkey. But there's so many things to choose from. There's turkey, there's stuffing, there's pumpkin pie, there's carrots. Do you like turkey, stuffing, or you don't know what you like? So maybe I reframed the question a little bit and threw in, or you don't know, because they were shrugging and maybe that's what they meant. Or I might jazz it up by doing something like, I see you shrugging, and sometimes it's really hard to know what your favorite thing is. And you actually only need like 2 more checks on this row before you get to go to the prize box. So for your next check, do you like turkey, stuffing, or something else? So that would be another way. So you want to ask the question twice. And if the child answers the second time and they say, even if it's really quietly, turkey, good telling me turkey, and we just continue. Now, the hardest one is when there's no response. So I'm going to make you guys feel what 5 seconds feels like. Do you like turkey, stuffing, or something else? That's 5 seconds, and it feels really long. And if your child does nothing, you would wait. And you can't say you're not answering. That's because that's not what, you're not describing they're not answering. You would just wait. You might think, well, was my question a good one? Like asking a 3-year-old what their favorite Thanksgiving food is might not be the best question. A better question might be, do you want me to put a heart on your paper, a star, or a circle? But let's say you asked a good question. You waited, you even jazzed it up and said, I know it's really hard to choose. And we were just talking about this the other day. I really like turkey. Dad really likes stuffing. Your brother really likes carrots. Do you like any of those things or something else, or you're not sure? And you wait 5 seconds and you don't get an answer. This is the hard part where you say, well, you know what? We'll come back to that later. And you go back to what we were doing before. It's just CDI. Which might sound something like, it doesn't mean forever, it just means for that moment. So what it might mean is that maybe you were at the aunt's house and you were playing before you go into Thanksgiving dinner, and you were doing 10 minutes of CDI, and then you started to go into VDI and you were playing, and then you asked a question and someone happened to walk by when you asked a question. Maybe that's why your child wasn't able to answer. Or maybe it was just an inconsistent answering, because that actually happens. Your child might be chatty and answering, and then they just kind of get stumped on a question. So you go, we'll come back to that. So actually we were drawing our turkeys. And so I'm going to pick up my pen and I'm going to start drawing again. Oh, good job picking up your pen. I see you're adding some colors. Looks like you're adding maybe some red there. I'm going to make it all red. Oh, you're going to make it all red. Thanks for telling me. I've never seen an all red turkey before. You know, I think I smell some really pretty delicious food out there. I think I saw some stuffing. And then maybe you'd come back to that question from before. So just as a reminder, what to do with a verbal response is to praise or reflect, or both if you can. If the question, we use in treatment a ton of what we call reinforcement in the way of a check mark. We also use stars or stickers, and we definitely identify prizes. And I'll just take a very quick sidebar to just answer a question that sometimes comes up, which is, but I want my child to answer because they want to do it. I don't want to incentivize them by bribing them. And what I would say is that using behavioral reinforcement, like a check mark or working towards prizes, is to me not bribery. Bribery, someone I know in the clinical world, I can't remember who, so I can't give her credit, I'm sorry, said bribery is what you do when you're really desperate. Like if you just talk to your teacher this week, I'll get you anything you want from the toy store. It like comes out of a place of desperation and is probably not going to work. Behavioral reinforcement is setting up a situation like, you know, this is pretty hard. And like you're 5 or you're 7 or you're 8. So this is tough and it's kind of hard to see how this is going to be helpful. So let's set some really clear contingencies around how to make it easier. So we're going to have a box, we're going to have a piece of paper with 20 boxes in it. And every time you answer a question, first to me and then in front of other people, you're going to earn checks. And then when you get to those 20 check marks, you're going to get a prize. What kind of prize? Could be something from a Target dollar bin, could be, you know, a special breakfast with mom. It could be just an extra few minutes of special time. It could be a toy. It could be anything. Okay. So this is just another presentation of what to do with a nonverbal response. So what were you for Halloween? And the child points. I see you pointing. I'm going to actually take that back. Let's say that you say, what would you like to drink? That's an open-ended question. And the child points to your water bottle. I think we'd all agree that the pointing is pretty clearly the child is pointing to your water bottle. So chances are they want water. But what I would say is, I see you pointing. And then ask, do you want some of my water or you want your own? Or you could say, do you want this now or you want it later? We really want to help shift away from the accepting, nodding and shrugging and gesturing as speaking. So we work a lot with families where a child might grab the parent's arm and the parent has become very good at distinguishing, that means I need to go to the bathroom, or that's because they want me to come with them. And we would say, you're pulling my arm. Did you want me to come with you, or did you want to stay here? So it's a very effective way of subtly shifting things. We talked a little bit about what to do with no response. So this is how we start treatment. We say, we want you to practice 5 minutes a day at home first, and then pick some planned and intentional situations where you can use these skills. And most people say, I don't understand. Why do I have to practice these skills at home? My child talks to me just fine. So why would I don't even think I'm going to be able to ask them questions because they're going to talk so much. Well, the reason is we want you to become fluent in the skills. It prepares you to use skills in any moment, meaning you're much more likely to be prepared if you are using skills on a frequent basis in a comfortable situation, so that when you go to these uncomfortable situations, like to get your oil changed where the guy is really chatty, you're going to have practiced these skills, so you're not going to be using them for the first time. And also your child starts to identify that you're doing it at a lot of times. Now, sometimes kids will say, why are you talking to me like that? And then you can say, that's a great question. Actually, this is how I practice brave. This is how I can practice helping you brave talk. Okay, so the next kind of move is to what's called the fade in. This is a little trickier to describe, but it's basically, now that I have the skills, how do I get my child to talk to another person? And basically that's what a fade in is for. It's to transfer speech from one person to another. And the rule of thumb is you don't move on to the next step without your child consistently responding at the step you're on, which means if, for example, your child talks to you in your home and you have your neighbor come over because your neighbor is really nice and wants to babysit for your child and you would like them to, and you sit in the kitchen and you say to the neighbor, we're actually, Jackson and I are going to color. I think I left some stuff for you in the living room. Do you mind going in there and checking it out? And that person goes into another room but is in earshot and maybe even in your sight line, and your child is consistently answering your questions with your neighbor 15 feet away, that's great. And that's one step in the fade-in process. The fade-in to get your child to talk to the neighbor would be moving that person a little bit closer and then a little bit closer while you continue to use your excellent skills. And eventually your neighbor, you don't have to teach you could have your neighbor watch a webinar like this, or you could just teach your neighbor really quickly. Here's the thing, we're practicing talking, but it's hard for my child to answer questions in the beginning. So when you come in, can you just occasionally say, oh, that's a good answer. Oh, thanks for telling us. Like you start to have the neighbor use some skills. So I'm going to show you, it's a lot of words, but it's basically what I just explained, that the child and the parent are playing alone first without a new person. Well, if you were in your home, your child does that. The neighbor comes in and kind of sits away from you, and the parent continues to engage in CDI and BDI, meaning some describing, some praising, and then some question asking. And then as the neighbor is coming closer, we want something to happen, which is we want to make the neighbor a little bit more interesting so that the child is interested in the neighbor. And maybe the neighbor just starts to make some comments or just starts to color, uses some CDI skills, in other words. And then maybe we have kind of two ways of prompting the child with the new person. For some kids, they just need a really good amount of warm up. And then the person could potentially, the neighbor could say, wow, That is a really, I see you drew red and orange and yellow. Are you drawing a rainbow or are you drawing something else? Your child might answer. Another strategy that's just a slight step down from that could be having the neighbor say, oh, tell mom if you're making a rainbow or something else. The tell mom might be just one tiny step in between directly telling the person. But you never move to the next step until you have success at the step you're on. And hopefully that makes sense to everybody. Here's a picture of what it kind of looks like. Obviously that's not real talking, that's just jibber jabber. But the person in blue is kind of coming a little closer. And then maybe they're making some comments. And you're always watching the child to see what happens. Might they get a little anxious? Yes. But as long as they're still responding to the parent or the person doing the fade in at any volume, we would keep going. Now this fade in could be done, just to go back for a second, it doesn't have to be led by the parent. So for example, if in number 1, let's say the child speaks a little bit to a teacher, that teacher could fade in someone else, meaning teacher and Jackson. I keep saying Jackson because that's my son. So if Jackson is playing with the teacher and they're talking and the idea is to fade in a speech pathologist, you do the same process with the new person. You could do the same process with a peer. So fade in is the process of getting blue person or new person into the talking circle. Okay. Oh, I just noticed a typo. I apologize, but I'm gonna have to tolerate the typo, which means I have to practice distress tolerance because it says, what's a direct command for nonverbal? It should say behavior. So I think this is actually pretty important, which is why I made this slide. A direct command uses very clear communication, and you can request a nonverbal behavior. So for example, if I said to a child, go ahead and point to the one you want. Go ahead and show me what you want to have for snack. Go ahead and take the one you want. It actually doesn't reinforce a nonverbal answer. Now this might be very confusing because it probably sounds like what I've just been telling you not to do. But let's finish the example and I'm going to ask the hosts if they need clarification. So to me, saying to a child who is in a situation, let's say child's at Thanksgiving table, and there's no way that they're ready to tell the whole group what they want to eat. Like that's just not appropriate yet. I wouldn't ask a question that I don't think my child can answer. So I might at the table say, I might hold out a plate of cookies and say, go ahead and point to the one you want. If I said, do you want this cookie? And they shook their head, then I've asked them a question and they've nodded their head and I've accepted the nod as a yes. So I use direct commands, and we want you guys to use direct commands for nonverbal behavior as long as you're not asking it as a question. So I'm going to give one more example. There's a place near where my office is where they sell cupcakes. It's called Sprinkles. And when I take kids on exposures with their parents, what we do is we go in to the store and it usually sounds something like this. Oh, it's so busy in here and it's always so loud in here. Oh, look at all those delicious cupcakes. Come on over with me to the counter. And they have like a big glass window separating the cupcakes from the kids. And then we look and I say, Jackson, look at all those cupcakes. Go ahead and point to the one you want. Now he points to chocolate. And he didn't nod. I didn't say, do you want chocolate? And he nodded his head. I said, do this, like point to it. And he did. And then I could say, oh, you pointed so fast. Thanks for pointing. Do you think that is chocolate, vanilla, or something else? Now I asked my question. So it can be helpful in that situation where you think it might be hard to find out what he wants. And so it would be really helpful if you knew first, so you could say, go ahead and point. I also teach direct commands to teachers because teachers can't just start asking forced choice questions and assume that the child's able to answer. They might need a fade in first. But if a teacher was told, you know what, please don't ask my child questions, but if you say, Susie, there are a lot of snacks you can have, go ahead and pick the one you want, then she takes the snack and you've had a successful moment because she followed that instruction. So I want to turn it over to the host to make sure that distinction is clear.
Yeah, that is very clear.
Okay.
Direct
Great. Command
and the nonverbal.
Correct. And so it's really actually helpful because also if you it allows your child to communicate, and at the same time it doesn't reinforce not talking. So go ahead and show grandma what you got from the American Girl doll store. She goes over, she shows her the doll, she did and then you could say, oh, great showing. So go ahead and is a wonderful way to start any direct command, which is much more effective than if you said to a child, maybe you can show me the one you want. I'm not sure if you want the child to show them or not, but if you say, go ahead and show me, that's pretty clear. Okay, so oftentimes in treatment, what treatment looks like is two simultaneous trajectories. One is coaching the caregivers in the use of skills, building momentum with the child, which means once the fade-in has happened and the child is speaking to, let's say, the clinician, then we do things like we take it on the road. So we do lots of surveys around the office, even just opening the door. Most of us would say we never open a door in a therapy session. However, when you're working with a child with SM, our doors are always open because we can say, so, you know, what were you for Halloween? A unicorn. A unicorn. Good telling me unicorn. And with my friend Aliana walking by. So you want actually to generalize by having the door open and going into different locations and asking people questions and answering questions. And so we do a lot of things like surveys, meaning let's find out what favorite candy people have in the office. Let's make a prediction. I think people are going to guess Skittles. What do you think? I don't know. You don't know. Good telling me you don't know. Go ahead and take a brave guess. Twix. Twix. Good answer. Okay, so you write Twix. I'm going to write Skittles. I really hope mine wins. Let's see if yours can win. And then we go around the office and we do a survey. Consultation means that often there has to be work with the school. And we could probably have a whole webinar, and maybe we can someday, about how to work with school when there's an anxiety disorder, especially SM, because consultation to school often looks like doing a training like this. It often looks like coaching, not usually live coaching, that's what we do for parents, but often some level of consultation with someone or a team to help the child in the classroom and where they're at. So for some kids, it starts with getting a parent or a babysitter or a caregiver to school 5 to 10 minutes, a couple times a week, when school isn't even, before school or after school, just to practice talking in the classroom with nobody there. Okay, so this is what a person can do while waiting for a fade-in, meaning, so it's not helpful to tell teachers or tell people what not to do. It's more helpful to tell them what to do. So I don't know why I guess I keep talking about Thanksgiving because it's next week, but let's say your child has difficulty talking to some family members. You could tell the family members, okay, we're working on talking. You know that Susie has a hard time talking, and so she's probably not going to be chatty at the table at Thanksgiving, but you know what you can do? You can praise anything. Like, I love that you're sitting with us. You could say, Jackson, I lost my napkin. Please hand me a napkin. You can describe what he's doing. I see you're eating a lot of really good, I see you're eating a big piece of pumpkin pie. And you can be engaged and you can be interested. So if you're sitting next to the child, like, I'm so glad you're sitting with me. You know, it's nice to see you smile. I haven't seen you in a long time. I think the last time I saw you, you were a bit smaller. So you didn't hear me ask the child any questions. Okay. So a couple other things before we wrap up. What is targeted practice? It's exposures. What is that? It's a planful place or situation that you create to practice talking or practice bravery. Where can you do it? Just about anywhere. School, family gatherings, stores, coffee shops, birthday parties. Now you might be thinking, well, I go to these places all the time. So isn't that an exposure? No, because you got to add the what. So it's an exposure when you planfully do approach a situation with a goal. So you do have to know where your child is at. So let's say your child at this point rarely talks anywhere when you're out of the home. A place to start would be to purposely go places that are not super crowded and prompt them to engage with you. So for example, go to Target, to the place in the front where they have all like the $1 and $2 thing, and be like, I'm going to look at my watch and I'm going to make 60 seconds, find the most interesting or funny thing. So you're engaging them in a physical activity. And then maybe you might just ask them a question when no one else is around. Now, maybe you do that already, but you probably haven't been then praising them for answering after they do it. So, okay, I found my thing and you found your thing. Cover yours up and I'll cover mine up. Okay, 1, 2, 3, show it. Oh my gosh, we found the same thing. Did we find hats or did we find silly socks? Silly socks. Silly socks, good telling me. I love hearing your voice. So these are examples of where you can do things and what. Prompting your child to answer your question precedes prompting them to answer someone else's question. I would also say that having your child order is not easy. And even if your child speaks at the table at a restaurant in front of a clerk, making the jump to ordering might be really hard. And so what I actually sometimes suggest to people is you can do it right in front of your child or separately. Ask the waiter, we're working on answering and practicing answering questions. Can you please ask my child, do you want chicken fingers or a hamburger? So sometimes when the child is asked a question, it's easier. Here's an example of some things that you could do on play dates. One would be to begin with friends where the child is most comfortable. Sometimes that means having play dates at your home. That's fine. I think that sometimes parents are nervous about how it will be perceived. And so it is totally reasonable to email another parent in a classroom and say, we're really working on practicing play dates. And my child really would love to play with your child, but we're going to invite you over a bunch of times. I hope that that's okay with you because we're kind of practicing play dates in our own home first. A lot of families or other people are more than happy to accommodate that. So here's an example of how to scaffold or kind of provide some structure for play dates. So if you have a play date and your child's happy to go off and play alone with Lily or Mary, great. However, if in your mind you say, I'm going to take 15 minutes of that play date and I'm going to structure it to help my child talk. So we can just read the cupcake one. So the parent says, Sam, do you want to add the eggs or the flour first? And Sam says eggs. Thanks for telling us eggs. Taylor, go ahead and tell Sam if we should use 2 eggs or 20 eggs. 2 eggs. Thanks for telling Sam we should use 2 eggs. Now, you actually don't even know which child is the one with SM because it doesn't actually matter because the skills are great for all kids and you can involve yourself in the activity. So we find that having a structured activity sometimes helps decrease your own anxiety about having a play date because that can be stressful. I know play dates are stressful for me. And it gives a structure and often instructions like, oh, we're going to paint these birdhouses, and then while they're drying, you guys can go play. So Mia, do you want to use red or green first? Red. Thanks for telling us red. James, tell Mia if red's your favorite color or if it's something else. So these are some games that we love. And really any game can be made more verbal or less verbal. So for example, everyone probably knows the game Candyland, which is for many kids the first game you play. You could really play that game completely silently or pretty silently. Okay, you turn a card, this one turns a card, and you just move colors. You can also make it highly verbal. Did you just turn over a card with 2 greens or 1 green? Zingo is a great game. It's a game like bingo, but with chips. Headbands is also a great game. It's kind of like 20 questions, where you wear a headband and you have a picture on your head, and you have to each person has to try to guess which one they have on their head. I will say it's a great game for kids who are like 7 and 8, but not so great for kids who are younger, because you really have to have the cognitive ability to hold in your mind. You have to remember the questions you asked. You have to remember not to tell the person what they're wearing on their head. So you want to really look for developmentally appropriate games. And I'll finish by saying there are a couple really great websites you can go to. One is ADAA.org, which you saw at the beginning, and when I turn this back over to the host, they're going to probably show that to you again. Another one is selectivemutism.org. That's the Selective Mutism Association. It was formerly the Selective Mutism Group, Child Mind Institute, and Parent-Child Interaction Therapy International if you're interested in more information about PCIT. Thank you so much for the time. I really appreciate it as always. And I'm going to just turn this back over to the hosts for some final thoughts.
Great. Thank you so much, Dr. Bussman, for your presentation. So wonderful to learn.
Pleasure.
All about selective mutism and those treatment techniques we can all use. So thanks everyone for watching our webinar, and feel free to email your questions to webinars@adaa.org, and please write Dr. Bussman in the subject line and we will get your questions to her. So bye for now, and we'll see you next time.